Hello, Web Shadowers. Welcome back. Thank you all for joining us this afternoon. Today, we have the pleasure of hosting Dr. Oruwari, who will be teaching us about breast oncology. As always, please remember that the Google form will be posted in the chat box and in the description of this video at the end. With that being said, Dr. Oruwari, you may start whenever you're ready.
All right. Hi, everyone. Hope everybody's doing well today. I believe this is my third time doing this for you guys, and I wanted to kind of switch it up a little bit because I'm not sure if it's the same audience or if it's different people. So some of the slides are the same, some are different. With this being Breast Cancer Awareness Month, I wanted to kind of talk a little bit about the importance of early detection. So that's kind of the focus of this, but I'm going to do quite a bit of an introduction in the beginning. So with that, I will start. So I am Jovita Oruwari. I am an oncologic breast surgeon. I don't know if you can see because I can't quite see my slides. Oh, there we go. Okay. I'm an oncologic breast surgeon and basically do breast surgery. It pertains to breast cancer, but I also do a lot of things that are not cancer. Oh, there we go. So how does one become a breast surgeon? Well, it takes 4 years of college, at which point you do your MCATs, 4 years of medical school, 5 years of general surgery residency, then 1 or 2 years of breast surgery fellowship. Once you are done with fellowship, then you can become employed at a teaching hospital where you can do academics, or you can become employed at a community hospital. You can go into private practice where you have partners, or you can go into a private practice where you practice by yourself. So there are all sorts of options, and there are pros and cons to all of them. And some physicians like one versus the other. I am currently employed at a community hospital. I was previously with a group, but now I'm by myself, employed by the hospital. And for me, that's just kind of the best way. Again, different for everyone, but that's what I'm doing. The scope of my practice involves really all ranges of breast care. So I see patients who come in with breast pain. I see patients who have breast lumps, patients who have cysts on their breast or in their breast, patients that have nipple discharge, patients that have a mass in their axilla, which is the area under the armpit, women who come in with breast infections. There's all sorts of skin lesions of the breast, rashes, etc. And then people come in with mammograms that are not normal, or they come in with a family history of breast cancer, or they're at high risk for breast cancer. So they want to talk about how do we screen for breast cancer moving forward. Some people come in to get genetic testing, or some people have had genetic testing and they come in to discuss the results. And then there's some women that come in with an actual breast cancer diagnosis. And men also come in with problems, either lumps or pain or breast cancer. So for you guys, what you need to learn and understand as you begin your medical journey is that every patient's encounter is going to begin with a good history and a good physical exam. This is something that's going to be reiterated to you by pretty much every physician that talks to you. This is the basis for all medical practice and all medical care. You have to obtain a good history from the patient, and you have to, as a physician, do a good physical exam on the patient. So for me, history as pertains to a patient that comes in to see me with a breast problem, these are some of the things that you want to talk to them about. Or this is the information that you want to get from these patients. You want to know from them, how long have you had the complaint? If it's a lump, how long has a lump been there? Has it been there 2 days or 2 years? When was it first noticed? If it's a lump, has it grown bigger? Has it gotten smaller? Is it painful? What makes it feel better? What makes it feel worse? How old were you when you started to menstruate, and how old were you when you finished menstruation? So these are important for our breast patients because it helps me in that initial analysis to start to think, is this going to be something benign or is this going to be something malignant? Because I know that people that are younger are less likely to have breast cancer. People that are older are more likely to have breast cancer. And then have they ever been pregnant? Because we also have data that tell us that women who don't get pregnant by the age of 30 have a higher risk of developing breast cancer. So those are all pertinent questions for my field. How old were you when you had your first child? Again, pertinent. Do you take birth control or do you take hormone replacement? This is also pertinent for what I do because hormones can cause breast pain and they can also increase risk for breast cancer. We also want to know if there's a family history of breast cancer because it tells me what level of suspiciousness should I have for this patient with their current complaint, and also alerts me as to whether I need to test this particular patient for genetic testing. Then I want to know if this woman has had previous breast surgeries and what were the surgeries for, were they benign, were they malignant? And the final question that I want to know is, have you ever had radiation to the chest? This is important for us because history of previous radiation increases the risk for breast cancer. And this could be radiation for childhood cancer like lymphoma or thyroid cancer, where the breasts were included in the radiation field. Over time, this will increase the risk of breast cancer. So this is something that we need to be aware of as breast surgeons. So you're done with the history taken from the patient. You've gotten all the information that you need. Now you need to do a good examination. You do a general examination, which includes listening to the heart and lungs, which is the basics of physical exams. But what's really important for a breast surgeon is that breast exam. A self-breast exam is when the patient examines themselves. A clinical breast exam is when the physician examines the patient. It's important to examine the whole breast, including the area under the armpit, which we call the axilla, including the area going up to the clavicle, because some breast tissue can go up to the clavicle bone. So it's important not to miss anything. It's really up to you, the technique you develop to do a breast exam, as long as you encompass all areas of the breast. Some physicians will divide the breast up into 4 quadrants and then take each quadrant individually so that they don't miss anything. Some physicians will go in a circular fashion, and some people just do it randomly. But whatever you do, just make sure that you evaluate every portion of the breast and you're not missing anything. So once we've done the breast exam, I will typically follow that up with some imaging. The imaging that's important for a breast surgeon are breast ultrasound, mammography, and breast MRI. Those are our 3 key imaging modalities. So this is a breast ultrasound image. The breast ultrasound we can do pretty much in anyone, all ages, young people, older people. And it's a good test for evaluating lumps, because just feeling for a lump is not enough. Most women in their lifetime at some point will have a cyst. A lot of times it's not noticeable. Sometimes it gets to the point where it can be palpable. So the ultrasound tells us that it's a fluid-filled lump, so we can then put a needle in and drain it. And that's all we really need to do with it, if anything. The picture on the left is what we call a solid lump. So that means that there's no fluid in it. It's made up of all tissue. So if we put a needle in, we would not be able to get any fluid out. So this is a lump that we typically want to biopsy to see what it is. The second imaging modality that's important for breast surgeons is mammography. The mammogram is basically an X-ray of the breast that uses low dose radiation. So not enough radiation to cause cancer, which is a common question that people ask. And we image the breast to look for lumps. In this picture on the left, you see kind of that whitish area there. That is a small breast cancer. So it's able to pick up lumps that we cannot feel. That's the importance of mammography. Mammography is better for older women because as we get older, our breasts get what we call fatty. We lose a lot of the structure and integrity of the breast. So a lot of the dense tissue that we see the breast, it's much harder to pick up these lumps, and that's why ultrasounds are better in younger women than older women. But in any case, this is a mammogram image. It's recommended that women 40 and above get mammograms once a year for screening. And this is important, and you can't skip years. Doing it every year is important because we're looking for, again, those small breast cancers that we cannot feel. And every once in a while, we recommend that a woman get a mammogram younger than 40, and that's typically women who are at high risk for breast cancer or have family members that were diagnosed with breast cancer at a young age. My third imaging modality that's important to us is a breast MRI. MRIs use magnetic resonance to evaluate the breast. And it's more sensitive than mammograms and ultrasounds. It finds things even smaller than mammograms will. We don't do mammograms on everyone because it's such an expensive modality. So we try to do this in women who we know are high risk for breast cancer, women who already have breast cancer, to evaluate the breast looking for additional lesions. So this is not something we do all the time. It's used in special circumstances. Once we get the imaging underway and we find something, a good percentage of these things that we find on imaging, we're not going to be able to feel, and we need to biopsy them. So in order to biopsy something that we cannot feel, we rely on mammograms and ultrasounds to do what we call a needle biopsy. So a needle biopsy essentially means that we're going to numb the skin and then pass a needle through the anesthetized area into the area of concern and take a little sample. And we send that sample to the lab to be looked at by pathology. So this is one way of evaluating things that we see on imaging. So this is another example of that needle biopsy. This is using the ultrasound on the left. The ultrasound finds the area in question, and then we direct the needle to where the lesion is. And on the right is a stereotactic core biopsy, which is doing exactly the same thing as the picture on the left, except that we're using the mammogram in this picture. Again, we anesthetize the area and pass the needle through the numb area, and the needle is directed to the lesion, which we're able to take a small sample and send it to the lab to be tested. Like you see on this diagram on the right. And then we go in, take out the area in question and remove it entirely, and then stitch it up. So the lesion goes to the pathologist to be tested in the same way that we do with the needle biopsy. So once it gets to the pathologist, what we are looking for from the pathologist is this a breast cancer or is this benign? And as a breast cancer surgeon, everybody thinks everything that I see is cancer, and that is just not true. There are so many things that we see that are not cancer. I see all ranges of benign breast diseases. So women come in with nipple discharge, which a lot of times is what we call an intraductal papilloma, which is a benign breast lump. Some people come in with breast pain, which turns out to be fibrocystic breast disease, again, benign. Women can come in with redness of the skin of the breast, which we diagnose as a breast abscess, which is a breast infection. There are skin changes that we see that could be a dermatologic condition like eczema. And then a lot of times lumps that we feel or see on the pictures when we do the biopsy turn out to be fibroadenomas, which again are benign. So there's a wide range of things that we see that are not cancers. But there are some things that we see that are cancers, which is the value of a breast cancer specialist. So breast cancer, for the most part, starts within the milk ducts of the breast or in the milk sac in the breast. If you look at this diagram on the left, just kind of a quick, simple diagram of the female breast. And you can see the nipple here. Going into the nipple is a network of milk ducts. This is where the milk actually travels through to come out of the nipple through the ducts. At the base of the milk ducts are what we call lobules or sacs. This is where the milk is actually stored. So breast cancer can develop in the lining of the milk duct or in the lining of the milk sac. If the breast cancer develops in the lining of the milk duct, we call it a ductal breast cancer. If it starts in the lining of the milk sac, we call it a lobular breast cancer. And then furthermore, we subdivide that into what's called in situ or invasive breast cancer. In situ, or some people say in situ breast cancer, means that the cancer cells are contained within the boundary of the sac or the lobule. And invasive means that the cancer cells have broken out through the boundary of the sac or the lobule. So this kind of shows you a better picture of what I'm trying to explain here. So, and this is the diagram showing that the changes are going on in the milk ducts, but keep in mind that these changes also go on in the milk sac. So the leftmost picture is a normal duct. So those, in the inner circle here, those little square looking things are cells. So the cells line the inside of the duct, and this should be a normal duct, and that's how they look. When it develops into an in situ carcinoma, those cells become abnormal, and those cancer So we have the normal duct, then we have in situ cancer, and then we have invasive cancer. So in situ is contained inside the duct. Invasive has broken out of the duct. The reason we worry about invasive breast cancer is because once the breast cancer breaks out of the duct or the sac, the next place that it can go to are those lymph nodes that I talked about under the armpit. Once the breast cancer makes it to the lymph nodes under the armpit, the very next place that it can go to are other organs in the body. So it can go to the liver, it can go to the lungs, it can go to the bones in the brain. And that's when we say that a breast cancer has metastasized. So when we talk about breast cancers in the scope of things, you don't want the breast cancer to spread out of the breast into the lymph nodes because the risk of it traveling further is very high. So now that we know that, let's talk about how we stage breast cancers, which you hear so much about women with breast cancer. Oh, they were stage 1, they were stage 4. What does that mean? So when we stage a breast cancer, there are 3 things that goes into staging. The one is the T factor, the second is the N, and the third is the M. T is the tumor size. How big is that lump? How big is that lesion that we see on the mammogram or on the ultrasound? So if it's 0 to, oh, it kind of has it wrong here. Anyway, if it's 0 to 2 centimeters, it's called a T1. breast cancer. That's the size. T1 is 0 to 2 centimeters. T2 is 2 to 5 centimeters. If it's over 5 centimeters, it's T3. T4 means that it's gone beyond the breast. It's in the skin, it's in the chest wall, it's elsewhere. So that's a T4. So for our practice, as far as early breast cancers, we consider T1 and T2s early. When you get to T3s and T4, that's usually a later cancer. So the second thing we look at is the status of the lymph nodes. So those are those lymph nodes under the armpit, which is the first place that the cancer would go to. N0 means that the cancer has not gone to the lymph nodes. N1 means that, yes, it has gone to some lymph nodes. And N2 means that there are multiple lymph nodes involved. And then the last factor is the M, which is metastasis. And it's just, has it traveled beyond the breast or not? If it hasn't traveled beyond the breast, it's M0. If it has gone to other organs like the skin, the lungs, the bones, the liver, then it's M1. So these three things, we kind of put them together to create a staging system. So stage 1 breast cancer is a cancer that is less than 2 centimeters. So it's T1. And it hasn't spread to the lymph node. So it's N0 and it's M0. So that's stage 1. It's contained in the breast. Stage 2 breast cancer is still less than 2 centimeters, but it's gone to the lymph nodes under the armpit. Stage 3 breast cancer is 2 to 5 centimeters and has spread to the lymph nodes. And a stage 4 breast cancer has spread to other organs. So the last stage of breast cancer is 4. It means that it's gone to the bones, the lungs, etc. And then it doesn't show that on this picture here, on this diagram, but the stage 0, which is actually the very beginning. Stage 0 is that in situ breast cancer we talked about. When it's still contained within the duct or the sac, is stage 0. So these are the stages of breast cancer, and now you know how we come up with the staging system. So now that you know how we come up with a staging system, what's the use of it? Why do we even stage it? What's the importance of it? Well, the importance is that 1, we want to determine treatment options for the patient, and 2, we want to determine a patient's survival based on their stage. So what are the treatment options? As far as surgery, which is, I'm going to kind of concentrate on surgical options. The options that I give to women who have a breast cancer is they can do what's called a lumpectomy. And that just means that we are going to go in, we're going to take the cancer out, we're going to get a nice shell of normal tissue around the cancer, take it out, stitch it back up. It doesn't change the shape or size of the breast. Versus we're going to go in and we're going to take the whole breast, which is a total mastectomy. And as far as options go, when we do a lumpectomy, the cure rate and survival is typically the same as removing the whole breast in women that have small breast cancers. And that's why finding the breast cancer small is important, because women have the option of having the lumpectomy without having to have the whole breast removed. But when we do a lumpectomy, we always follow it up with radiation therapy. That makes the cure rate equivalent to doing a mastectomy. And this is just a diagram showing a woman who's had a mastectomy. We've removed very cosmetically and looks pretty good. And then women who go on to have their breast removed have options as far as breast reconstruction. So we can do reconstruction using breast implant. This is a typical silicone implant. So this would be placed by a plastic surgeon under the muscle. And it's just a way of rebuilding the breast that we've removed. So if you think of taking out the breast tissue as unstuffing a pillowcase and then putting this in and as stuffing back the pillowcase, that's what the implants do. And then there are other ways to do breast reconstruction where instead of putting in an implant, we can use the woman's body parts. So we can either use fat and muscle from her stomach, or we can use fat and muscle from her back. So that's just based on the latissimus muscle back here above the scapula. And they kind of swing that forward and replace the breast tissue with that, or take the belly and fat and kind of move it up. And the cosmesis is excellent for these surgeries. Plastic surgeons do an amazing job. And then additional treatment besides the surgery for breast cancer could be chemotherapy or radiation. Some women need surgery, chemo, radiation, all of it. Some women need just surgery. Some women need just surgery and chemo, surgery and radiation. Just different combinations, again, depending on the person's stage at presentation. Is it a stage 1 breast cancer? You're going to be treated less aggressively than if you were stage 3 or 4. And then finally, what I wanted to kind of make sure that everybody gets out of this, the importance of early diagnosis, the importance of the staging system that we use. So a stage 0 breast cancer that's contained or confined to the breast, when we take it out and do all of the treatment, the cure rate and survival is just about 100%, which is amazing. Same with stage 1 breast cancer. So these are early detection, stage 0, stage 1, very early detection, cure rate 100%. I usually tell my patients cure rate 95 to 100, because I'd never like to say 100%, but over 95%, which is excellent in either case. Stage 2 breast cancer, you get to the upper 80s, which is not bad either. But when you get to stage 3 breast cancer, so you're talking about it's going to the lymph nodes and has a chance of going elsewhere, the cure rate starts to drop 61%. And when you get to stage 4 cancer, the cure rate is 20%, so it's much less. So again, this is importance of early detection. This is why we talk about women going in for the yearly screening, doing breast self exams, trying to find things sooner rather than later, because we know that the sooner we get it, the more likely we are to treat it and to cure it. And that's what treating breast cancer really is all about, okay? So that is my talk today. I'm gonna stop here and see if there are any questions. Bring that up, okay, so.
Thank you so much, Dr. Oruwari. I sent in some questions from our participants.
Family history that makes them high risk? And that's a good question. So as far as being referred, it's different for different insurances. Some insurances, you absolutely have to have a referral from your primary care doctor. Some insurances, you can just call up a specialist and go see a specialist. But if your primary care will not refer you, you need to, and I stress this to a lot of women, you need to advocate for yourself. You need to bug the heck out of them, call the office, torture them, whatever it takes, and say, I need to see a specialist, and just advocate for yourself. And if that doesn't work, you may need to switch primary care doctors and see somebody else. What are the risks of breast reconstruction? So the risk, first of all, same risk for every surgery, which is risk of bleeding, risk of infection, risk of nerve damage, etc. For reconstruction in particular, with the implants, there's risk of implant rupture, where you'd have to go back and switch out the implant. There is, for the bigger surgeries, there's risk of implant failure, which means that just a small percentage of women will not accept, their body types will not accept the implants or will reject the implants. So would have to take out the implants and they'll have to go without. And some people who have the bigger surgeries where we take the muscle and the fat, you can't really do sit-ups anymore because muscles from the belly are gone. Some people don't mind that. So this is something that the plastic surgeon usually kind of goes over everything with patients beforehand. The majority of patients I see opt for implants because it's much quicker, much easier surgery to heal from. It limits your activity much less than taking muscles from your stomach or from elsewhere. Are there dietary changes that you consider important for a patient going through or recovering from breast cancer? Absolutely. Research shows that the closer you are to plant-based, the better it is for breast health. We're not saying that you should become vegan or you should become vegetarian, but definitely a diet that's rich in fruits and vegetables is going to be better for your heart, better for everything. So that's what we recommend to our patients. Let's see. How often do stage 0 breast cancers get detected? Today, with the advent of mammography, very, very frequently. I would say probably about 70% of the time we find early stage breast cancers because women are getting screening. Will surgery be performed if it has attached to the chest wall? If so, what are the risks? So if it's attached to the chest wall, I would not do surgery right away. I would do surgery eventually, but not right away. So these are the women that I would send to the medical oncologist first to do chemo first. The aim of chemo is to try to shrink the cancer away from the chest wall so that we're able to have an easier time at surgery, because the worst thing you want to do at surgery is start to take chest wall, because then we start talking about radical surgeries or radical mastectomies, which we don't really want to do today. And besides which, chemo and radiation would be more effective to treat in a breast cancer that's that far advanced than surgery. But it's a huge topic. I just kind of brushed it quickly there for you. But I just did not enjoy obstetrics and gynecology.
Hi, Dr. Oruwari.
Yes.
You kind of cut off a little bit when you were answering the question.
Oh, I'm sorry. Can you hear me now?
Yes, I can hear you now. Thank you.
Oh, okay, no problem. So I think the question was what made me choose oncology and specifically breast cancer. So my answer was early on, I wanted to be a gynecologist, but I did not like my rotation. I did not enjoy that, but I still wanted to do something in women's health. I enjoyed my general surgery rotation. And somewhere, I believe in my 3rd or 4th year of medical school, I met a female surgeon who all she did was breast cancer surgery or breast surgery. And then there was one of my chief residents at the same time was interested in going into the same field. So I pretty much shadowed both of them. And they had an immense influence in my direction or my path in life. As someone interested in plastic surgery, would you say there's a big overlap working with plastic surgeons related to reconstruction of breast after tumor removal? Absolutely. We work together all the time. So there's a wide range of what plastic surgeons do, but one of the main things they do is breast reconstruction. So we actually tag team the surgery. So I would come in and do my part. Say we're doing a bilateral mastectomy. I would come in and do the right breast. When I'm done removing the right breast, I'll go get started on the left, and the plastic surgeon will remain on the right to do the reconstruction. So we're working together to decrease the amount of time that the patient is under anesthesia. It works best for the patient, it works great for us, and I've never met a plastic surgeon that I didn't like. We all work well together, and it's a great team effort. How does diagnosis way of approach differ between male and female breast cancer patients? Like, what else does a surgeon look for besides estrogen and fat levels? Actually, there's no difference. We treat breast cancers in men the same exact way we treat them in women. Diagnosis is the same. We do the mammograms, what I like to call the manograms, because we're doing a mammogram in a man. But yeah, we do mammograms, we do ultrasounds, we do the biopsies in the same way. The only thing is that because men have such little breast tissue, a lot of times they are not good candidates to just do a lumpectomy or to try to preserve the breast. So a lot of times would have to do a mastectomy on a man. The options for chemotherapy, radiation, all the same, treatment the same for a man. When applying to medical school, what did you find to be the most challenging aspect? How was the process for you? Luckily, I did not have too much of a problem. I think for me, the most challenge would be that I had such an interest in so many things outside of the sciences. And I felt so limited because I was a biology and chemistry and math major minor. And I felt that I would have loved to do the arts. I would have loved to take literature. I would have loved to do some music that I didn't have an opportunity to because I was just so science and math heavy in my major. So what I would recommend to you guys is if you have other interests, this is kind of the time to try to explore it. Take whatever you need to get your MCATs accomplished, but take English class. The medical school, would you study for
Hi,
the exam?
Dr. Oruwari, I'm so sorry, but you cut off again. I
Oh,
think
I did. I'm sorry.
yeah. The
Okay,
last thing I
is
heard
that?
was English class.
Oh, I was just saying, yeah. Just so that you're a well-rounded person, try to take other classes outside of medicine, outside of sciences. So English, literature, African studies, whatever it is that you enjoy, that you find of interest, I would say go ahead and do it. I actually have one of my old partners was a flute major in college and just took her prerequisites for the MCATs. And I just feel like she's the most well-rounded. When you were studying for the medical school examination, how did you study for the exam, if you can remember? Oh my gosh. I just remember that I used to study a lot, a lot. Certainly lots of books. I just did a lot of those prep books. And I was really well prepared, I feel, because I studied a lot for it. And that's just what you have to do. Just work hard. It's not impossible. Let's see. Is breast cancer approached differently in transgender patients? No, not differently. It's the same. Breast cancer is going to be approached the same regardless. Would you recommend the gynecomastia patients coming for screening more regularly? I take it you mean gynecomastia as in male? No, they do not need to be screened more frequently. A lot of times when I see a male with gynecomastia, which just means extra breast tissue in a man, it's more common around the teenage years and then from the 60s or onwards. A lot of times it's hormone related, a lot of times it's medication related. If we can find the root cause, if it's medicine related and stop the medicines, it usually starts to regress. It's a source of emotional angst for teenage boys because they get teased a lot in school because, when they wear a t-shirt, it looks like they have breasts. So they come in seeking surgery to have it removed. We usually wait at least a year or two, and if it doesn't go away, then there's a small surgery that can be done to remove the extra tissue. If the person doesn't care, we can leave it be. It doesn't really cause anything bad to happen. Do you find disparities with breast cancer in minorities? Well, absolutely. There's disparities in medicine as a whole in minorities. For breast cancer in particular, the incidence of breast cancer up until recently was much less in African American women than white women, but the death rate or the risk of dying from breast cancer is much higher in African American women. The reason is African American women were less likely to seek medical care, so less likely to get mammography, less likely to go to the doctors when they felt a lump, less likely to have insurance to go to see a doctor. They're less likely to have access to healthcare. So there's a lot of issues why there are disparities, and we are working continuously to try to bridge these gaps, to try to bridge the disparities that exist. But there's definitely disparities, and it's just important to learn the reasons why so that we can get to the patients where they are. Okay, I don't see any other questions. I think that was it.
I don't see any more. Those are all of the questions that I saw. So thank you so much for answering all of them.
You're welcome.
For taking time out of your day to present for us again. We loved all of the visuals that you provided us and how passionate you are. It's always an honor to have you back. Thank you.
Thank you so much. I'm going to take a picture of my screen real quick.
Okay. The link to today's Google form. Thank you. The link to today's Google form has now been posted, and it will be in the description of this video at the end. So please fill it out as soon as possible to receive verification for your attendance. And yeah, thank you so much, Dr. Oruwari. It was an honor to have you back.
You are welcome. Have a good day, everyone.